We're going to be talking about both aplastic anemia and PNH today. I'll talk about a little bit of disease etiology, or what causes the disease, how we diagnose it, and treatment. And as it relates to PNH, I'm going to talk about one special population as well. So for aplastic anemia, the background, as you can see, it was characterized a long time ago. It was first described actually in a pregnant woman who passed away of marrow failure. And the final, the term aplastic anemia was coined a few years later, but that's a bit of a misnomer, as you may be aware. So anemia is not the only issue with aplastic anemia. It's probably better referred to as aplastic pancytopenia because more than just the red cells are reduced. It's an ultra-rare disease, so less than 1 in 50,000 people will have it. It seems to be a bit more common in Asian populations, and especially in Asia, not just Asian populations who actually move to North America, and possibly with a bit of a environmental cause, as it seems to be at higher incidence in rural areas in Asian countries. There's a few different peaks: childhood, about the second decade of life, and around the 50s and 60s. Most of the cases are idiopathic, meaning we're not exactly sure what's causing it. There is evidence that it's immune-mediated, so the immune system is actually affecting and fighting against the blood cells, but there's not a clear target yet that has been identified. The potential causes, triggers, and mimics I've listed here. So pregnancy, as I mentioned, was actually the first association with aplastic anemia. There's an association, especially in young men, with a seronegative hepatitis, where we can't actually find a virus that's causing liver inflammation, but there's a clear relationship there. Other conditions such as autoimmune conditions, infections, drugs, and then unrecognized inherited bone marrow failure syndromes, especially in younger people. You have to consider that there could be actually a congenital issue that presents very similarly to aplastic anemia. As I mentioned, it does seem to be immune-mediated. That is supported mostly by the fact that patients will respond nicely to immunosuppression, about 80%. There is an increase in various different types of white blood cells. So T cells in a couple of different subsets of T cells are increased. And there's an increased level of inflammatory cytokines or molecules as well, something called interferon gamma and a few others. There are a few other things as well. So it looks like there's actually possibly inherited or just intrinsic defects in the stem cells, or what we call the bone marrow microenvironment, so other cells that support the bone marrow. And there are also some genetic issues that may actually increase or decrease your susceptibility to getting aplastic anemia, and may also change your response to immunosuppressive therapy. Presentation is variable. Sometimes people are completely well and it's just actually found on a blood cell picture that was ordered by the family physician. Anemia tends to present, as I'm sure many in the audience are aware, with being pale, fatigued. You can have exertional symptoms such as chest pain or shortness of breath that are new to you. Thrombocytopenia or low platelets can be associated with bleeding. In aplastic anemia, it's usually what we call mucosal bleeding, so nose bleeds, gum bleeds, much more common than more severe bleeding, such as intracranial or in the head. And leukopenia and neutropenia, low white blood cells, again, usually presents with impaired immunity, chronic or recurrent infections. As I mentioned, sometimes people will often be well before or even when they're diagnosed. They may have a long-term history of a minor cytopenia, so a long-term anemia that wasn't responding, or people have been previously labeled with ITP or immune thrombocytopenia. But the investigations that we do to work this out, again, a CBC or complete blood count, your red blood cells would be low. Usually they're of normal size. And we also have reduced reticulocytes or immature red blood cells, thrombocytopenia, low platelets, and low white blood cells. Other things that should be tested, so the coagulation or clotting profile should be normal, and looking at blood chemistry, there should be an absence of blood cell breakdown or hemolysis, unless you have PNH, which we'll get to, and liver enzymes should be tested just in case there's this preceding hepatitis picture. Looking at the bone marrow, which you have to do for a diagnosis of aplastic anemia, we find very few cells. That's why it's called aplastic. There's absent or reduced platelet precursors called megakaryocytes, The red blood cell production is reduced, and there may be some slight dysplasia that you can also see in MDS, but it tends to be less so, and it should be restricted just to the red blood cells. And there's also an increased lymphocytes and fat cells, and I'll show you a picture of that. So this is what it may look like. First, this is the peripheral blood film. Essentially, you can see that we have red blood cells, hardly any little platelets here. On the peripheral blood, on the bone marrow smear, so the liquid part of the bone marrow, there's hardly any blood cell production other than a few what we call plasma cells, a little bit of a red blood cell dysplasia. And this is the core biopsy where almost no cells are present other than these fat cells. And the fat cells may actually play a role in ongoing suppression of blood cell production, and that's an area of research going on right now. This is how we diagnose aplastic anemia, the Cometa criteria. We look at neutrophil count, platelets, and reticulocytes, and also the bone marrow, looking at the cellularity and moderate disease. So severe disease is if your neutrophil count is less than 0.5, you would be labeled very severe disease if your neutrophil count is below 0.2. Moderate disease is just not fulfilling these criteria, and chronic is anything over 3 months. Some of the additional tests that we would do is looking actually at what the blood cells look like under the microscope to look for increased blasts, to actually do a cell count to make sure that we're not dealing with something like MDS. Flow cytometry to look at other conditions that may look like aplastic anemia, also to identify the Pnh clone, and we'll talk about that going forward. Cytogenetics, as Dr. Yee mentioned, is very important, and this is something that will sometimes help us decide whether or not it's aplastic anemia or MDS, especially if we're dealing with a hypoplastic variant of MDS, where there should be fewer or no cytogenetic abnormalities in aplastic anemia. And other things can be considered, including a workup for inherited or congenital bone marrow failure, and if there's a consideration for bone marrow transplant, it's the time to consider HLA typing. Again, I just showed you a blood film of aplastic anemia, and you might think that this looks like the same one. However, I'll just point out here that this, again, we're hypocellular, so not a lot of cells. This is a special stain called CD34, and what that shows is that there's actually an increased blast count. So this is actually not aplastic anemia, but hypoplastic MDS. So as you can see, it can be a bit challenging to decide on what you're treating without these special stains. Again, that's aplastic anemia, that's hypoplastic MDS. So in terms of treatment for aplastic anemia, close monitoring can be done with non-severe disease. With severe disease, you want to, or in general, you just want to assess general fitness. Sometimes you may be limited to supportive treatments, blood products, etc., as well as things to help reduce bleeding, such as antifibrinolytics, something called cyclocapron or tranexamic acid. And it's important to establish a plan early. I'm sure you've all, especially if you have the condition or are a caregiver for someone with it, you realize it's important to have a plan early to, again, avoid excessive transfusions if at all possible, and to delay treatment in general to prevent infections, which can be a complication. So bone marrow transplant is the only curative option for aplastic anemia. It is the treatment of choice in younger patients. That's usually less than 40, although some centers will do less than 50. The goal is to get the donor's cells to engraft without any graft versus host disease. Matching sibling donors are preferred. Unfortunately, only about a quarter of us have that option. And you have to be cautious if you're suspecting the potential for a congenital marrow failure syndrome, because you can be transplanting that same condition back into the patient. But it tends to have fairly good results with the long-term overall survival around 80 to 90%. Also, matched unrelated outcomes are improving. So this used to be not an issue for consideration, but due to better conditioning, better treatment in general for transplant patients, this has become an option. There are also advanced matching techniques to find better donors. There's still an issue for non-Caucasian patients, just due to the fact that most of the unrelated donors are Caucasian. Long-term overall survival is around 50 to 65% right now, but that does decrease with age, hence the reason to consider it just in around 40 to 50 as the upper limit. There are some late complications that you have to be aware of and would be gone over with you and your physician. So chronic graft versus host disease, there's a risk for other malignancies in the future, lung disease, infertility, failure of the donor graft, and the progression to actually myelodysplastic syndrome. So for those in whom transplant is not an option, we consider immunosuppression. This is for either older or unmatched patients. Most of the regimens include something called ATG and cyclosporin, and these are also usually treated alongside with corticosteroids or prednisone to reduce the chance of getting something called serum sickness with the ATG. The response rate is pretty good, about 80%, and it is better if you have higher pre-treatment reticulocytes, those immature red cells, or higher pre-treatment lymphocytes, a type of white blood cell. Better response, definitely if it's seen early, within the first three to 6 months, and if you're younger, so less than 40. That said, relapse still occurs in about 15 to 30% of patients. So in refractory or relapsed disease, immunosuppression is unsuccessful in about 30 to 40%. So for relapse, that essentially means that you have a new need for immunosuppressive therapy to restart, or new transfusion dependence, or you're dependent on one of the immunosuppressive agents, cyclosporin. There are some options that are available. So transplant is a consideration, usually after 1 or 2 additional trials of immunosuppressive therapy. You can repeat a course of this ATG. Usually you're given what's called horse ATG, or it's actually from a horse. Rabbit is another product that tends to have a good response. About a third of patients will respond if they're refractory or if they relapse. Something called Campath, which is a monoclonal antibody against white blood cells. There are also androgens, essentially male hormones, something called danazol or oxymethylone, which they use in the UK. This is not upfront therapy and has variable response. It tends to work actually in some patients who have something called telomeropathy, where a bit of the ends of the chromosomes are a bit shortened for various reasons, and there seems to be an increased benefit in those patients. There's also Tipo Agonists. Tipo is similar to EPO that Dr. Yi talked about. So Tipo is called a thrombopoietin. It's a hormone that increases the production of platelets. And there are several of these agonists. 2 are on the market right now, Eltrombopag and Remiplastim. Eltrombopag, which is also known as Revelade, has been tried and shown to be effective in refractory aplastic anemia. Currently, it's not fully approved for this, but there are some ongoing studies. You can get it for compassionate release, and there are studies actually looking at it in combination upfront with immunosuppressive therapy. So there are some options coming down the pipe. So I'm going to switch now to PNH. So this is a very brief immunology lecture, and it's just 2 slides, I promise. So just to give you an idea of what PNH is, you have to understand just a little bit of the complement system, which is a part of the immune system that protects us mostly against viruses and bacteria. It's a very prehistoric system. You can find this type of thing in coral. It is very tightly controlled, and there are 3 different pathways. I'm not going to walk you through this, but if you follow it all the way down, you can see there's this thing called the membrane attack complex, MAC. And the membrane attack complex is a protein structure that essentially looks like a protein spigot. It gets stuck into the side of an invading virus or bacterium and causes that cell to explode or otherwise to become damaged and die. And complement is what is, for various reasons, dysregulated in PNH. You're missing 2 very important molecules that protect our own cells from being damaged by complement, something called decay accelerating factor and CD59. So there's a whole list of complement-mediated diseases. We're just going to be talking about PNH today right at the top. It was similarly described back in the late 1800s by Paul Strubing, and it was in a young man who voided dark urine only in the morning. He had progressive intravascular hemolysis, so his blood was breaking down within his blood vessels. And it looked to be distinct from other causes of hemoglobinuria at that time, something called March hemoglobinuria and paroxysmal cold hemoglobinuria, something completely different. Again, it's another misnomer. Why? Well, paroxysmal means that it would happen here and there, but it actually looks like low-grade hemolysis is ongoing all the time. Nocturnal, meaning it happens at night, but it actually happens at any time of the day. In some patients, they do notice an increased activity at night or darker urine right in the morning. And hemoglobinuria, which is in the name, is actually only present in about a quarter to maybe 2/3 of patients. So not the greatest name. It's an ultra-rare disease again. About 1 to 2 per million per year will acquire it, and we probably have, right now we have 127 patients across Canada in our registry. There is a classical triad of presentation. So what happens is you get hemolytic anemia, bone marrow failure, and thrombophilia, or an increased predilection or risk of developing blood clots. That said, there are many other common clinical features that often precede this classic triad. Fatigue and abdominal pain are very, very common and associated with that an impaired quality of life. Renal failure or kidney failure, if you look for it, is present in around half of patients to some degree. And smooth muscle dysfunction is also noted because of decreased nitric oxide in the blood because of hemolysis. And that can occur and present as shortness of breath, something called pulmonary hypertension, diffuse esophageal spasm or difficulty swallowing and painful swallowing, and erectile dysfunction in men as well. It's caused by a mutation on the X chromosome in a gene called Pig-A. And this gene is important for the synthesis of molecules that stick out on the side of the cells and then bind to other effector molecules, these two that I just showed you in the complement figure, CD55 and 59. And this is what it looks like in cartoon form. Essentially, we have a glycoprotein or a sugar and a protein bound together, and here at the top is where the effector molecule would bind. It gets produced inside the cell and then finally gets expressed on the outside of the cell. And if these are there, that protects our cells from being broken down and destroyed by complement. But in PNH, we're missing that. And just to show you in pictorial form again, in panel A up here, we have a normal set of complement regulatory molecules. So if complement gets activated, it tries to bind to these red cells, but it can't. And even if there's a lot of complement activity and that membrane attack complex forms, this MIRL is another name for CD59. It blocks it from being deposited on the cell. In panel B, we have a PNH cell. So no complement protection here. Complement is binding to it. The complement gets activated right to the end. We have the membrane attack complex deposit within it, and then we get a lysis of the red blood cell. The PNH clone tends to be quite small, but in PNH patients who actually have classic disease, that expands usually to over 10%. Classic disease is usually associated actually with a clone of over 50%. There are some additional mutations that have been identified that may increase the growth potential of that clone. It has actually been reported by some that even quote-unquote normal people have very small PNH clones, but that tends to be kept in check by the normal bone marrow environment. So this figure here just shows you this little red cell is the PNH stem cell clone. These other cells are all the normal ones. At some point, we think that there's some type of immune attack or other stress on the bone marrow, similar to actually one hypothesis for aplastic anemia. And the normal cells get destroyed, but the PNH clones, for various reasons, do not. And from that PNH clone stem cell, you get all the production of the other blood cells, so red cells, white cells, and platelets. And if you have PNH red cells, again, missing complement protection, they break down and hemolyze within the blood vessels. You get release of hemoglobin, which is free hemoglobin, which decreases nitric oxide, and a full list of signs and symptoms that have a direct impact either on quantity of life, survival, or quality of life. Just to give you a brief idea of how we diagnose PNH, of course you have to have some symptom for your physician to suspect it. But definitive testing is done by high sensitivity flow cytometry, so actually staining your blood cells to look for the presence of these GPI molecules. And why is high sensitivity important? Well, as you can see here, about 40% of PNH samples have small clones, meaning less than 1%. And that is most common in conditions such as aplastic anemia, and to a lesser extent and with less clear clinical impact in some myelodysplastic syndromes. Flow cytometry, this is very brief just to tell you what we're doing. There are different stains that bind to either these GPI molecules or the actual cells for us to identify exactly what we're looking at. And on the printout, these are your granulocytes, or you're called your neutrophils. And when we look at two different things that should bind to GPI, they're absent. And this tells us that we have about a 72% PNH clone. So that's a large clone, probably associated with clinical disease. The red blood cell assay is a bit different. So we also look at your red blood cells and stain them for CD59, again, the complement protector. And there are three different types of cells here. So type 3 PNH cells are red cells that have absolutely no GPI expression or no CD59 expression. Type 2 have reduced, but there are some GPI anchors present, and type 1 cells are completely normal. And so this is a PNH patient who is not on treatment, and though I haven't talked about treatment yet, if we block that hemolysis, if we block those cells from being broken down, you can see that now the same patient on Eculizumab, their type 3 clone, which was about 15%, goes up to 78%. So that is really effective in stopping that intravascular blood cell breakdown or hemolysis. And this is an acronym that the Canadian Pnh Network is using. It does need some modification and improvement, but reasons that we think physicians should consider testing for PNH. So unexplained cytopenias, meaning why an unexplained low blood cell count. Aplastic anemia or MDS. Definitely in aplastic anemia, a PNH clone should always be done at the time of diagnosis and actually followed probably every 3 to 6 months for the first little while to make sure it doesn't expand. Thrombosis or blood clotting is an important one, especially if it's completely unexplained otherwise. Coombs negative hemolysis, so a type of hemolysis, and hemoglobinuria or hemoglobin found in the urine. So what is the relationship with aplastic anemia? It's a two-way relationship. It actually may be that these two diseases are on a spectrum of one disease. About 40% of severe aplastic anemia patients will have a PNH clone, and about 15% will actually expand to the point where there's clinical disease, clinical PNH disease. On the flip side, about 1 to 2/3 of PNH patients eventually progress to some degree of cytopenia or even aplastic anemia and require treatment for that as well. The presence of a PNH clone may actually improve immunosuppression, improve response to immunosuppression in aplastic anemia. And something similar, though, with much less robust evidence, has suggested that there may be, if a PNH clone is present in hypoplastic MDS, there may be some response or improved response to immunosuppression. Thrombosis is a very important condition to consider in PNH. It's quite prevalent. About 1/3 of patients will develop a blood clot at some point in their disease. There's an increased involvement at unusual sites. So instead of the classic deep vein thrombosis in the leg or blood clot in the lung, you can get blood clots in the abdomen, around the liver or the spleen, or also CNS or in the head. It's also still right now the leading cause of mortality, so very important for your physicians to be aware of this. Of course, the first recognized thrombotic event can be fatal, so it's very important to protect from that if at all possible. And if thrombosis does occur, there's an increased risk of mortality going forward in the next about 10 years. As I mentioned, the distribution is a bit different. About 1/3 of patients here had fairly common DVT or pulmonary embolism blood clots in the lung, but here we can have abdominal clots. This is actually skin vein thrombosis or blood clots. And of course, as I mentioned, what everybody is most concerned about is cerebral venous occlusion or a blood clot in the blood vessels in the brain. And we're learning more and more that it looks as though that the clone size increases the risk of thrombosis. So you can see that patients here, this is data from our global registry. If a clone is greater than 50%, the incidence of thrombosis increases or blood clots increases. Similarly, having just an elevated LDH, which is a marker of hemolysis, higher than 1.5, the upper limit of normal of wherever you go for the blood test, also has an increased risk of thrombosis. So management of PNH, supportive in the past has just been essentially there's transfusions, red cells. Even when we put patients on Eculizumab, which I'll get to, about a third of patients will actually still say transfusion dependent for various reasons. Platelet transfusions are exceedingly uncommon except in certain circumstances. You might end up being iron deficient because of blood loss, possibly through the urine from hemoglobinuria. That said, if you're persistently transfusion dependent, sometimes, and I have a couple of patients here in Hamilton that actually require chelation therapy because their iron overload is so high because of long-term transfusion dependence. There are also some additional therapies as well. I'm not a bone marrow transplanter, but just so you know, the use of bone marrow transplant in PNH has definitely reduced since the availability of Eculizumab. Right now, it's really considered only for refractory disease while on Eculizumab, or if it's a small clone and it's aplastic anemia being the major issue. So Eculizumab, I've mentioned a few times. You may already be aware, but this is a monoclonal antibody that blocks a part of the complement system. It blocks C5, and by doing so, it stops the formation of the membrane attack complex being deposited on the red cells, white cells, and platelets. And these are various studies that were published back in 2006 and 2008. There was a pilot in 2004, as well as a study in 2011 in Japan, all of which showed that after you start patients on Eculizumab, their LDH level, which is again a marker of blood cell hemolysis, drops immediately to just above the upper limit of normal. This lighter blue line up here is the placebo group from the TRIUMPH study, and at week 26 you can see they were all given Eculizumab and also came down to join the rest of the group here. And this is a sustained response. What's important to realize, and people in the audience may actually have experienced this, that quality of life improves quite dramatically after starting this drug, and that is despite stable hemoglobin. So this red line here shows you from week 0 to the end of week 26 in the TRIUMPH randomized controlled study that there was really no improvement in hemoglobin level in the Eculizumab treated patients. Despite that, their Facet fatigue score, which is a score that we use to gauge just general fatigue and quality of life, where a change in 3 or more is clinically significant, the score actually went up by 6. So there's something else that's happening by just inhibiting complement activity that leads to improved quality of life, better energy, less abdominal pain, even if the hemoglobin doesn't necessarily increase right away. And Eculizumab doesn't just improve quality of life, it looks now that it actually improves quantity of life. So this is a chart or a graph, from the 1995 Natural History paper. This is much before Eculizumab. And you can see that in a non-malignant condition, this condition had a 5-year mortality of about 35% despite best supportive care. Now, these patients on Eculizumab, this is from data from Leeds in the UK, this now essentially travels along the same line as the age and gender matched population. And we have data now out to about 13 years with a slight drop off around 10, and that's because of progression of marrow failure, not complications of thrombosis or hemolysis. And so Eculizumab, for the most part across Canada, you need a granulocyte clone or a white blood cell clone of PNH to be over 10%, and you have to have evidence of high LDH or hemolysis, and at least one of these other events. So having developed a blood clot, ongoing anemia or transfusion dependency, or renal or insufficiency or pulmonary insufficiency, or these smooth muscle spasms that I had mentioned earlier on. It's a once weekly infusion for the first 5 weeks. There's an induction phase for the first 4, and then at week 5 you get a slightly higher dose, and then it's a fortnightly or every 2-week infusion thereafter, long term. It's important, as members of the audience may be aware, that you have to be vaccinated against meningococcus or Neisseria meningitidis. We need complement, especially the last part of complement, to protect us against these infections. And so for that reason, before starting or at the time of starting eculizumab, it's important that you receive these vaccines, something called Menactra, or a quadrivalent vaccine, and there's a new one that's been on the market now in Canada for the last year and a half or so called Bexsero, which protects against serogroup B meningococcus, which is actually the most common in our country. Treating thrombosis or blood clots in PNH is pretty straightforward and very similar to what we do in general. You start with a heparin, something called low molecular weight heparin, if at all possible, and transition to warfarin or Coumadin. The only difference really is that if you're not yet on eculizumab, it's important at that time to start it. It's an indication to start it immediately because it treats the underlying cause of the blood clot. I just wanted to introduce a couple issues about special populations. So PNH in pregnancy in the past has been almost universally discouraged by physicians because all parameters of the disease got worse. Anemia got worse, increased transfusions, definitely an increased risk of blood clots, which is an increased risk in pregnancy in general. You can see here in the pre-eculizumab era, up to 1 in 5 mothers would pass away because of thrombotic complications if they tried to carry a pregnancy. And stillbirth rate was around 5 to 10%. Eculizumab, as I've just shown you, makes patients feel better. Some will say they feel back to normal, and that has translated into an increased interest in conception and having a family. So I just wanted to share this with you. This is a paper that was just published last month, and the Canadian Pnh Network was involved in this. And this was an international case series of 75 pregnancies and 61 women. And we looked at, and they were all treated with eculizumab. So as you can see here, about half of the mothers who were able to carry the pregnancy past the first trimester had breakthrough hemolysis, meaning that their disease was getting out of hand, and this had to be managed either with increasing the dose or increasing the frequency or both of eculizumab. Red cell transfusion requirements also became more of an issue again. You can see about 1/10 of a unit was required in the entire 6-month period prior to conception in these women. And then during their pregnancy, they required just under 1 unit on average per month. And after delivery, that returned back to their baseline. From a platelet perspective, as I mentioned, platelet transfusions are not often required in PNH patients unless there's concomitant marrow failure. Platelets were required in 16 of the cases, 9 right around the time of delivery. Looking at the risk of blood clots, which has been the major issue in PNH in pregnancy in the past, just under 90% of the patients were treated with some form of anticoagulation or blood thinning to protect them from getting a thrombosis. There were no thrombotic events, no blood clots at all during pregnancy. There were 2 that occurred immediately postpartum. 1 blood clot in the leg and 1 mesenteric or abdominal vein clot. And that was actually in a woman who was given a lot of plasma blood product because of postpartum hemorrhage. And plasma has a very high concentration of complement, so probably what happened there was that it just overwhelmed the eculizumab that she had on board. There were also 2 blood clots that occurred after 2 mothers stopped their eculizumab. So in the UK and continental Europe, you can actually be given eculizumab just as pregnancy being the indication, even if there's no other indication there. And probably the best part of this series was to see that there were no maternal deaths whatsoever. Looking at the fetal complications, a similar stillbirth rate around 4%, a miscarriage rate around 8%, and 1/3 had premature births. And when we looked at exposure of drug to the newborn, there was no detectable eculizumab in the cord blood in about 2/3 of patients, and very low levels in 1/3. And in the mothers who decided to breast milk, we tested 10 samples, and there was no detectable drug there. So it doesn't seem to expose the fetus or newborn to the drug. And finally, just one other area, there's a Obviously, again, patients who are feeling well might start going back for general surgeries such as orthopedic surgeries, hip replacements, knee replacements. And right now we're not exactly sure how best to deal with eculizumab around that time, but we do know that surgery increases complement activity. So the general practice right now is to time surgeries, if at all possible, within 7 days of the last infusion of eculizumab to make sure that you have good protection on board. If there is breakthrough during the surgery or during the hospitalization, we'll often try to get an additional dose of eculizumab at that time and then restart that 2-week cycle from the new infusion date. It's also important to alert one source, which is the patient support program for eculizumab, just especially if there's a plan for a longer admission, just to make sure that you're not going to miss a dose. And I just wanted to introduce you to the Canadian Pnh Network. It's a group across the country, 12 centers, and essentially our vision is that patients in Canada must receive world-leading care that extends over case recognition, diagnosis, and treatment, and our mission also reflects that. These are the various members. I'm not sure exactly where everybody's from, but you can probably see somebody who's relatively close to you. The head of our network is Dr. Richard Wells, who I'm speaking on behalf of today, and I'm here in Hamilton as well, and you can see the rest of us across the country. This is a website, so it's phnetwork.ca. It's mostly for physicians right now, but we're working on improving some patient information as well. But it is free. You can go to it and have a look. And again, just wanted to let you know that if you do have PNH, or if you have aplastic anemia and you are known to have a PNH clone, and you're not within the registry, there is a registry that is available, and any of the people on this map can enroll you in that if you're interested and consent to do so. And the reason that we do that is that PNH is so rare that it's very expensive and very difficult to run randomized controlled trials for any new therapies that might be coming down the pipe, or just randomized studies in general. And so registries following patients long-term is really the best way of doing that right now in an observational manner. And right now, as of last month, we have about 3,800 patients across the globe, 35 countries participating. And as I mentioned earlier, we have 127 patients right now enrolled.